to review some of the images, some of the cases, and maybe even make sample reports for yourself at this point. How this is going to work is basically I chose 5 cases that you might see on call that are, relatively common but important findings, and, some a little bit of challenging cases. And basically I'm going to work through the cases and show you how I might write a sample report, and then also go through some important learning points for each case. So let's get started. So this first patient is a 35-year-old female presenting with 2 days of increasing headaches and new left-sided weakness. So first we got here the axial non-con head CT, and the first most critical finding that we see here is their intraparenchymal hemorrhage in the right parietal lobe. We see some edema around it. We know it's acute because it's dense and because there's, the edema around it, which tells us it's acute hemorrhage. So a young patient like this, it's a bit peculiar. I don't see any signs of trauma. There was no history of trauma. The scalp soft tissues look pretty clean. Other things you got to think about here are arterial venous malformations would be something to consider. But another big one, particularly with hemorrhages or even just edema sometimes in the parietal lobes and the temporal lobes, if there's risk factors, young patients, is another big one you have to think about are venous hemorrhagic infarcts. So if we look closely, this might be tough if you haven't looked at too many head CTs, but once you get kind of used to it, this will stick out a lot more easily. The density in the sinuses here we see, as well as some multiple cortical veins here, but the superior sagittal sinus is very dense. And if we go down, straight sinus and vein of Galen are also too dense, as well as the left transverse sinus down here as well. So if you look just for a quick comparison, it's tough to tell here, but like, for example, the right internal cerebral vein here is more normal density, and the vein of Galen, straight sinus, and kind of the sinus confluence here are a lot more dense. They're too dense. So this is suspicious for dural venous sinus thrombosis and subsequent hemorrhagic venous infarct. And then we confirm this on the CT venogram here. We see the right transverse sinus is filling nice and normally. The left transverse sinus is not. The superior sagittal sinus also not, and the straight sinus here as well. A little bit of an example of kind of the empty delta sign, if you've ever heard of it, where you have this central filling defect and a little bit of sliver of contrast around the outside of it, or here as well, giving a kind of delta shape appearance. And you can see that both on CT and MRI. So sample report, acute intraparenchymal hematoma centered in the right parietal lobe. I like to talk about the degree of mass effect. So there's local regional mass effect, but no midline shift or herniation. That tells neurosurgeons that they don't necessarily need to go in and operate right now, for example, to decompress the brain. And then I talk about the hyperdensity in the superior sagittal sinus, straight sinus, vein of Galen, etc. And that basically just says that this is suspicious for acute clot, because acute clot tends to be dense on CT. So in conclusion, talk about the right parietal hematoma, and then it's suspicious for a hemorrhagic venous infarction, and then you should get further evaluation with CT or MRI venogram. So the pathology, when you have a venous occlusion from clot, you get retrograde venous pressure, and that can kind of lead to leaky vessels. You can get vasogenic edema, some petechial hemorrhage, and then the hemorrhage can actually become more confluent, and you can get kind of large intraparenchymal hematomas. And then often too, with one of the things that's relatively helpful for a venous infarct is you get kind of a combination of vasogenic and cytotoxic edema, because not only are you getting back pressure, vasogenic edema, hemorrhage, and things like that, but you're also getting stagnant flow, and that reduced flow can cause ischemia as well to the cortex typically. So usually what you'll see on MRI, for example, is like a hematoma with some edema around it, and usually kind of lots of edema, and then also the cortex in that region tends to be infarcted with cytotoxic edema on the DWI you usually see. Risk factors, idiopathic trauma, hormonal, pregnancy, I'll list here. One I wanted to highlight was tumors, and particularly meningiomas, because they're extraaxial. They often are near the sinuses, or they can invade the sinuses, and it's important to mention that in your report because it can affect the surgical management. Sometimes they might have to remove the sinus, sometimes they might have to, and then reconstruct it. Sometimes they might have to leave a part of the meningioma and radiate the patient afterwards, the residual meningioma. But either way, it just basically can affect management, and also promotes an increased risk of, shows that there's an increased risk of venous infarction for the patient in those cases. So clinical, pretty nonspecific headaches, focal neurological deficits, seizures, the CT hyperdensity in the sinus, which we talked about, empty delta sign, which I also showed you. And then the density, this is helpful, particularly when you're starting out. You're not really sure, is this too dense or not? If you put a Hounsfield measurement on it, it's usually in the 65 to 70 range. For too dense, that would mean that's hinting towards acute clot, which tends to be dense. But there are some pitfalls. This is a helpful clue, but there are some pitfalls. Beware. For example, if the patient just got recent contrast, maybe they had another CT recently, you can get residual contrast in the venous system of the brain. So that usually tends to be more uniform, but of course that can increase the Hounsfield units because there's contrast in there. In newborns, you can get physiologic polycythemia, so it's going to look dense, but that can be a normal finding in newborns. And then, CT technique, things like that. And if the patient's hematocrit is off, that could affect it as well. So MRI I really like for the dural sinuses, and particularly the post-clot MP rage, because it gives excellent venous opacification. So any filling defect is going to be very conspicuous. A pitfall with the MP rage is it's a T1 sequence. So if the clot, because of whatever reason, the age of the clot or something, happens to be intrinsically bright on T1, then it can blend in right with the contrast and you won't see it. So in that case, you have to work with other sequences. Maybe it'll be bright on diffusion, or maybe it'll be blooming on the GRE or something like that, that'll help you push you in that direction. But it's definitely a pitfall. And that's the reason I like to include, the MRV. The MP rage is great, but you can't just get rid of the for example, time of flight or post-con MRV as well, because, you need those because of that pitfall of the intrinsic T1 signal in some cases. Other hints, acute clot tends to diffusion restrict and bloom on GRE, SWI, so it can be very hypointense on those. And then you could lose flow-related enhancement on a time of flight MRV, and then loss of the normal flow voids on a T2 or flare. That's pretty nonspecific. You can also see that in the setting of just kind of normal sluggish flow. So mimickers or pitfalls. So mimickers of a filling defect, arachnoid granulations are really important ones. I've seen these overcalled as sinus thrombosis many times, but the helpful hints for these is they tend to be very round morphology. And on top of that, if it's a CT, quickly look at your non-con CT, because the arachnoid granulation is basically CSF filled, so it's going to be CSF density rather than more dense like a clot. And if it's an MRI, it's going to follow CSF intensity on basically all the sequences. So that's a quick way to realize, okay, I'm just dealing with an arachnoid granulation. You can get mixing artifact from emissary veins or suboptimal contrast bolus timing. That's another big one, particularly with the CTV. One of the reasons I like the MP rage MRI a little bit better, because it gets more uniform contrast opacification. And then some other pitfalls, sinus aplasia or hypoplasia, particularly common in the transverse sinuses. They tend to have some degree of asymmetry, as well as the anterior superior sagittal sinus. So be aware that just because the sinus is small and not really getting as much contrast as the other side, or doesn't look like it has much contrast, that's different from a filling defect where the sinus is normal caliber, but it's not getting any opacification because there's clot in there. So just be aware of those pitfalls. The next case is a 55-year-old male presenting for urgent surgical planning of a left temporal lobe lesion found on CT. So we look at the non-con T1. We see the lesion, not super conspicuous on the T1, but there's probably some degree of edema around it. We see here a little bit of relative hypointensity, quite a bit of mass effect. Look at the temporal lobe on the right side in comparison to the left. It's basically totally effaced. Even the sulci up here are very crowded in comparison to the contralateral side. We see it's enhancing. There's kind of thin peripheral enhancement, not really thick nodular enhancements, like typically favors a tumor. This is more thin, but not the best hint in this case. And it's actually very thin when you get to the ventricular margin here, and it actually looks like it's probably contiguous and might have extended into the ventricle. So there's also a little bit of a penile lining enhancement here, which is suspicious. So now, if you pay attention to the ventricles too, they're actually kind of out of proportion dilated. And we don't see any obstruction at the level of the cerebral aqueduct or the fourth ventricle that would explain an obstructive hydrocephalus. So now we're worried, if this is a tumor, is there potentially leptomeningeal disease, which is causing more of a communicating hydrocephalus, or this is an infectious process that has ventriculitis and that's causing some degree of hydrocephalus. It's not clear at this point, so what I like to do next, we look at the flare, also really shows that edema nicely. And we also see the ependymal lining here is very bright on flare, which tells us something's wrong. This could be leptomeningeal disease. This could be appendicitis from infection. And we'll look at all this layering debris in the occipital horns and the atria of the lateral ventricles, right? This is a flare sequence. This should be nice and black like the CSF up here, but there's a lot of debris in the ventricles here. So if we want to differentiate between tumor and abscess, the absolute best sequence to do it on is the diffusion, because pus essentially is very viscous, and because of that, you're going to get diffusion restriction. It tends to be light bulb bright, particularly centrally, like we see here. And it also ruptured into the ventricle, so you're getting a lot of debris, purulent debris in the ventricular system as well. So this patient also has ventriculitis and obstructive and communicating hydrocephalus as well. And we confirm on the ADC that this is true diffusion restriction here. One other hint here, some people like this a lot. I find the diffusion a lot more helpful, but some people like this dual rim sign where you have like an outer darker layer of the fibrocollagenous capsule basically, and then the inner portion, which tends to be a bit brighter on the T2, which is the granulation tissue. It's supposed to be specific for abscesses, but I've seen tumors that look pretty similar, so I don't love this one, but some people find it very helpful to hint that you're dealing with an abscess. So in my report, left anterior temporal lobe lesion with thin peripheral enhancement rather than thick nodular enhancement, which points more towards tumor, central diffusion restriction, and just one more point here, central diffusion restriction is because of the viscous purulent debris. This is more seen in bacterial or pyogenic abscesses. It doesn't really necessarily apply to fungal or other atypical infections. So keep that in mind when you see the central diffusion restriction. We're talking about bacterial abscesses in comparison to tumors. And there's lots of marked edema. There needs to be some degree of edema because there's some inflammatory process. Abscesses always usually have at least moderate edema around them, bacterial ones at least. And then in this case, we want to mention the ventricular rupture because that's a poor prognostic sign, and patients usually get rapidly sick in that setting, and also the hydrocephalus. So just kind of in conclusion, left temporal lobe abscess complicated by ventriculitis from rupturing into the ventricle and associated hydrocephalus. So etiology, they could be hematogenous from sepsis or endocarditis. It could be direct extension, usually from the sinuses, paranasal sinuses, or otitis media or mastoiditis, something like that. It could be postoperative or traumatic. And then in neonates, another big one is meningitis. Meningitis tends to be a kind of a precursor to abscess in neonates. Clinical other nonspecific findings, again, headaches, seizures, focal neurodeficits, elevated inflammatory markers. A big one I wanted to highlight, only about 50% of patients actually have fever. So don't be dissuaded if you're pretty confident someone has an abscess, intracranial abscess, and the clinician tells you, oh, there can't be, there's no fever. Only about 50% of the patients actually have fevers. And then again, rupture into the ventricles leads to rapidly worsening symptoms and poor prognosis. So it's important to mention that's an urgent phone call. Imaging in the early cerebritis stage before the abscess is mature, you tend to just see ill-defined edema, maybe some patchy enhancement. Then as it matures, you tend to have the more ring-enhancing, like encapsulated, lesion. And then on the post-con, it tends to be more thin rim of enhancement rather than kind of thick or nodular enhancement like you see in tumors. It tends to be thinnest on the ventricular side, which is easy to remember because they like to rupture into the ventricle. So the thin, weaker side of the wall is towards the ventricle. And then ADC, DWI is going to be the most important clue. Look for that light bulb bright diffusion restriction. If you're trying to tell apart a bacterial abscess from a tumor, look for the DWI. And then if you see rim enhancement without diffusion restriction, that should steer you away from a bacterial abscess and make you think maybe you're dealing with some sort of other process here. The last thing I'm going to mention, this is rarely helpful, but occasionally, more often in the postoperative setting, if you're dealing with a glioblastoma and you're not sure, is this an abscess that developed, a postoperative abscess, or maybe the tumor bled into the cavity, which is giving you some diffusion restriction, or did the patient have necrosis from like maybe Avastin, something like that, that's giving diffusion restriction. You're not sure, is this abscess or not? One thing that could help in these settings is to get an MR spectroscopy and look for a succinate peak at 2.4 parts per million. Companion case of a glioblastoma. See, this is why I like the DWI so much, because this almost looks like a dual rim sign here on the T2 with some edema around it. There's kind of thin rim enhancement here, but the diffusion, there's no central restriction, and this is a path-proven case of a glioblastoma. So, you really got to pay attention to everything. Diffusion is my favorite sequence for these, and it's the most helpful. 45-year-old male presents with altered mental status. This is the next case, and associated left-sided weakness. So not super subtle here, but we have this like superficial intraparenchymal hematoma here with some edema around it. We know it's acute blood because it's dense and there's edema around it. Young patient, no signs of trauma here, no history of trauma in this case, so that's probably unlikely. It could potentially be an AVM, that's one thing. Maybe you want to get vascular imaging. But the other thing I'm suspicious for is because of the morphology is very rounded and it's kind of superficial, almost near like gray white matter junction, a neoplasm is a little bit suspicious in this case, even without a history of it. So I'm going to probably look around for other potential intracranial lesions. And we see here in the medial left occipital lobe, and then you can also kind of hallucinate this one with me a little bit. The parasagittal left frontal lobe, there actually happens to be another tiny lesion there, but I don't expect you really, to pick that up. I know it's there because I have the MRI, which I'm going to show you, but it'd be very difficult to pick that up de novo in just from this CT here. But I'm worried mostly in this case about two things. One, if the clinician told me that this patient was septic, I would worry about potential septic emboli. Those often bleed because it's multifocal, kind of gray white matter junction. But similarly, I'm worried about neoplasia. And there was no really history of sepsis or anything like that. So I'm worried that this could potentially be hemorrhagic metastases. What I would do in real life here, I would take a quick look at the chest, abdomen, and pelvis if there's a CT available, see if there's other metastatic lesions, which will really tip me into the direction of metastatic disease. Check to look in the charts if he has any history of known malignancy or anything like that, of course, which would be helpful. But the quick look to the CT of the chest, abdomen, and pelvis is often helpful in these settings. And that helps too if you're looking between a primary glial neoplasm, primary brain tumor versus a metastatic tumor. If it's a solitary mass in the brain, you're not really sure. Quick look at the chest, abdomen, and pelvis can really help a lot in those settings. So on the MRI here, this is a T1 without. We see all this bright signal from the blood, but there's also this nodule here, which is relatively hypo-intense. And then if we look at the post-con, it's enhancing. So there's an enhancing nodule. Now we're very suspicious for intracranial metastases, hemorrhagic mets, and we see this actually lots of hemorrhagic lesions here on the SWI, including that frontal lobe and probably anterior thalamus here. So sample report centered in the superficial posterior right frontal lobe is an intraparenchymal hematoma with rounded morphology. That's a hint that maybe we're dealing with some sort of neoplasia. And then I say there's additional foci again, which can sort of hint that maybe we're dealing with some other systemic process, something like that. Coagulopathy also is another big one that can cause multiple sites of bleeding. So multiple hemorrhagic mass is suspicious for intracranial metastases, and then in that case, you want to recommend a contrast-enhanced MRI, like we saw. So common primary malignancies that are associated with hemorrhagic intracranial mets. So renal cell melanoma, thyroid, choriocarcinoma are very vascular, and on a case-by-case basis, they have a high tendency to bleed when they mets to the brain. Lung and breast, on a case-by-case basis, not so much, but since they're so much more common overall, they tend to be very, very common causes of intracranial brain mets. There's a huge differential for non-traumatic intracranial hemorrhage, hypertensive, usually basal ganglia, hemorrhagic transformation of ischemic stroke, obviously after a stroke. Amyloid tends to be more lobar. They might have a bunch of microbleeds, older patient dementia, neoplasia, coagulopathy, septic emboli. I don't put this list. I put this list here, one, for your reference, and two, to realize that when you see a bleed, you have to think about all these things, and it has to be, your findings need to be concordant with the clinical picture too as well. So the age needs to be right, the location, things like that. Otherwise, you should give a differential or speak with your clinicians and get some more information. I put this here also. For me, anytime I'm reading a case, and if it's not classic, if it's not an obvious diagnosis or something, very bread and butter, and there's something that smells off about the case, maybe the location's weird, the size, the morphology, the patient's age, or, I speak to the clinician, I say, hey, I think it's A, and the clinician says, oh, that doesn't really fit, our picture here. So in those times, it's really important to kind of be humble, take a step back and think, am I missing something here? And break things down into disease categories. I do this very frequently. I ask myself, could this potentially be a vascular lesion? Could this, like a stroke, for example, could this be infectious, inflammatory, traumatic, autoimmune, and so on and so forth? So it's something to kind of do in those situations where it's not a very clear-cut diagnosis. Hemorrhagic intracranial mets tips here. History of malignancy or metastatic disease, of course. Rounded morphology should be a little bit suspicious, particularly if it's like gray white matter junction location. Multiple lesions, that might be some sort of systemic process, whether it's coagulopathy or septic emboli, metastatic disease. Out of proportion vasogenic edema too is another big one, because acute bleeds always have some edema around it, but it's usually, relatively local. But if there's really kind of more moderate or extensive edema, you should be worried that maybe there's some sort of other process going on. Remember to check the chest, abdomen, and pelvis, like I mentioned before, to help you kind of look for other mets and narrow things down. consider other causes of spontaneous intracranial hemorrhage, and recommend in contrast enhanced MRI and follow-up. The reason you want to get follow-up too is because if you don't see a diagnosis at baseline, sometimes a small lesion could be obscured by a large hematoma, so you should get follow-up, make sure that resolves normally, and there's no underlying lesion. The next case is a 65-year-old presenting with unresponsiveness and hypertension with a systolic blood pressure in the 220s. So first we're looking here at the flare, and we see pretty striking cortical and subcortical edema, more of a parietal occipital distribution. It's relatively symmetric. We also see to a lesser degree kind of the posterior frontal lobes here, as well as the posterior and lateral temporal lobe here as well, and then even the splenium of the corpus callosum to some degree. So this is a good look for PRES, or posterior reversible encephalopathy syndrome. Sometimes I use the term acute hypertensive encephalopathy because PRES is somewhat of a misnomer, because this diagnosis is not always posterior and it's not always reversible. So it's some degree of a misnomer, and that's why I like to sometimes use acute hypertensive encephalopathy. So now we want to look for complications. Do we see any hemorrhage associated with the PRES? Not typical, but it certainly can have microhemorrhages or even more frank hematomas, which we don't see in this case. We want to look for infarcts. I don't really see any ischemic changes. However, what I do see, my eyes caught in the pulvinar of the right thalamus here, as well as the right hippocampus, there's pretty bright signal, and we confirm that on the ADC. This isn't shine through right. This is kind of similar to the parenchyma here, maybe even a little bit darker, as well as the hippocampus. So this is a good look for seizures. These are both very common areas for basically seizure-induced changes. If from acute seizure or status epilepticus, you can get diffusion restriction, usually in the pulvinar and or hippocampus, and sometimes the cortex as well can be other areas that are affected. Those are good areas to put on your checklist when a patient could be seizing. In this case, it makes sense. The patient has PRES, right? They're unresponsive, so PRES is associated with seizures, so it's very possible that this is basically PRES complicated by seizures. So our report, this is typical findings of PRES, relatively symmetric, cortical subcortical edema with a parietal occipital predominance, and there's importantly, there's no acute hemorrhage or infarction as a complication, but we do see findings suggestive of seizure in the hippocampus and pulvinar of the thalamus. So in conclusion, acute hypertensive encephalopathy with associated findings of acute seizure and no acute intracranial hemorrhage or infarction. Learning points. Possible etiology is thought to be due to a failure of autoregulation in response to acute changes in blood pressure. Posterior circulation tends to be affected a little bit more than the anterior circulation. That's potentially because of relative sparsity of sympathetic nerves. And then also, it's generally reversible when the causative agent is removed. Clinical, again, pretty nonspecific headache, seizures, encephalopathy, visual disturbance, vomiting, and there's many associations here. If you Google it, there's going to be a very long list. These are just kind of some of the general ones here to be familiar with. They're associated with PRES. MRI is a lot more sensitive than CT. If it's really extensive, you can see PRES on CT, but generally speaking, MRI is going to be a lot more sensitive. So the flare in particular is the most sensitive because flare nulls out the CSF, and these tend to be cortical subcortical edema. So if you have bright edema next to the nulled out CSF, it's very conspicuous in comparison to just a regular T2, where the CSF is bright and the edema is bright, it's less conspicuous. Typically, it's bilateral, relatively symmetric, watershed distribution. You may see hemorrhage or diffusion restriction, but it's usually not a dominant feature in a typical appearance. And then post-contrast, typically there's no enhancement, but there could be leptomeningeal or patchy cortical enhancement as well. So don't exclude PRES based on the presence of enhancement. And vascular imaging, you may see irregularity. This reminds us of the overlap in clinical picture and imaging features with RCVS, or reversible cerebral vasoconstrictive syndrome. PRES and RCVS overlap a lot, and sometimes they even coexist as well. So that's why it helps us remember the vascular imaging can show irregularity in PRES. Patterns, the typical pattern is the parietal occipital dominant pattern. You could also see superior frontal sulcal or holohemispheric watershed. And then the atypical patterns, in these cases, keep PRES in your mind, but you should probably give a differential, exclude other causes, and go back to that vitamin C mnemonic. Think about, could I potentially be dealing with something else, but keep PRES in your mind. If it's asymmetric, unilateral, extensive hemorrhage or diffusion restriction. Central PRES I have seen a few times. Usually how it is, you get a lot of edema and swelling. typically in the posterior fossa, the cerebellum brainstem, and it usually extends up into basically the thalami and basal ganglia as well. But again, these atypical patterns, you should probably consider other things as well. And then this last case here is a 70-year-old male with a history of metastatic lung cancer, presenting with right upper greater than lower extremity weakness and speech disturbance. So we're thinking maybe left MCA territory infarction here, potentially more lateral rather than medial because of the upper greater than lower extremity weakness. First thing I do, non-con head CT, I look for any bleeding, any significant mass effect, any obvious large territorial infarct I don't see. What we do see here are some parenchymal calcifications. In this case, it's because the patient had lung cancer. These are old treated metastases. That's what you're seeing here. They're incidental, not really relevant to the case in this one here. Next, I like to look at the vessels. I'm going to show you quick MIPS. The circle of Willis is patent. There's no large vessel occlusion. There's no large vessel occlusion in the neck as well. And this is important, of course, because this would be an emergent finding that the patient might need to go urgently to get a thrombectomy. And then next thing I like to look at the perfusion summary. So we see here, using the established thresholds, there's no significant reduction in CBF below the 30% threshold, and there's no significant elevation or delay in Tmax above the 6-second threshold. So great, we're thinking right now, okay, maybe this is going to be a negative, no stroke, anything like that. But one last thing you have to always do, I like to check the maps. The reason I like to jump right to the Tmax, the reason I like to jump to the Tmax is because the CBF, CBV tend to be a bit more heterogeneous because they're dependent on tissue type. For example, gray matter, white matter get differences in flow and volume and stuff like that. So they're more heterogeneous, and therefore any type of abnormality is going to be less conspicuous compared to the Tmax, which is independent of tissue type. So you get nice uniform contrast across the whole brain parenchyma. So any abnormality is very conspicuous. So I'll show you that here. Jump right to the Tmax. A lot more uniform blue color. And then we see here wedge-shaped delay in the area of the left MCA territory, which is concordant with what we were thinking clinically, right? We were thinking maybe left MCA infarct. And then we also see here on this Tmax summary, we see it's a mild delay greater than 4 seconds, but not at the 6-second threshold. So then we look at our vascular imaging. We're going to really hone in on that area, and we're going to trace this vessel out here. And we see, boom, right there, it disappears. So there's actually a proximal M3 occlusion on the left here in this case. So this is a distal medium vessel occlusion, or technically it's a proximal M3 segment occlusion of the left MCA, but it's under the category of distal medium vessel. There's no acute hemorrhage, no large vessel occlusion, which is pertinent negatives to mention in your reports. And then I say there is, however, a proximal M3 segment branch occlusion. And I say by the established thresholds, there's no core infarct or ischemic tissue at risk. However, there is a mild delay greater than 4 seconds to the left MCA territory. There's also a bunch of osseous metastases and things that are incidental in this case. But for the conclusion, I like to break things up by CT head, vascular imaging, and CT perfusion, and kind of restate those findings here. So distal medium vessel occlusion, they can be accurately detected with Tmax maps with very high sensitivity, but of the covered brain. I emphasize this because some CT perfusions only do the MCA territory, so they cut off the vertex in the posterior fossa. So if you have a distal ACA occlusion, or if you have like a posterior fossa occlusion, something like that, it might not be included, and therefore, of course, it's not going to be picked up on the Tmax. So assess for Tmax delays in a vascular territory. This can easily be these delays can be overcalled because for lots of reasons. So make sure what you're looking at is kind of wedge-shaped and in a vascular territory, because some of the things, the pitfalls with Tmax are these to be aware of. The big one is the border zone Tmax delay, the border zone like the watershed areas. So basically anything that's going to delay contrast or blood to getting to the brain is going to cause Tmax delay. And if it's kind of proximal to the brain, like in the neck, the heart, or the contrast injection itself, it's going to be more of those watershed distribution. Why? Because watershed areas are the last ones to receive blood and therefore last ones to receive contrast. So for example, if I have a right carotid stenosis, that's bad. The whole right hemisphere might have a delay in the watershed distribution. If I have poor cardiac output, from like congestive heart failure or something like that, in that case, you can get bilateral, like a mild delay in those border zone distributions as well. And then lastly, if the injection itself is poor, let's say the timing is off, the bolus is weak, something like that, the IV is not good, it's going to take longer for the contrast to get there. And where is it going to take the longest? Those watershed areas. Other things, Old infarcts, right, is going to show, it's going to come up as a Tmax delay, but it's easy to rule out. Just look at your non-con, has CT, and it should be very hypodense and old chronic. And then contralateral fetal PCA is another one. Anterior circulation tends to fill a bit faster than the posterior circulation. So for example, if my right PCA is being filled by my anterior circulation because it's a fetal type, it'll look like my other PCA territory is relatively delayed because it's not filling as fast, and therefore the computer can mix it up and show a relative delay on that side. But that's just physiologic. And then skull base artifacts, so artifacts in the skull base motion, but they're usually not vascular territory. They're usually pretty easy to tell apart. And then another big one, seizures, migraine. Seizures in particular, they usually cross vascular territories, which could be a big hint that you're not dealing with something vascular. And if it's post-ictal, they might have some relative hypoemia, so like you might have relative paucity of vessels on the MIP in that region without a true like filling defect like you would expect with acute thromboembolism. And then if it's ictal, they're usually the opposite, where the Tmax is actually like really rapid, and also you're getting like increased flow, hyperemic flow, so you're getting increased CBF in that affected area, and you might even have increased vessels in that area on the MIPS. And then always check for mild Tmax and delays, the 4 to 6 second threshold, because approximately 10% of distal median vessel occlusions are actually only going to have a mild delay and only show up on that 4-second threshold like we saw in our case. The reason for that, it's not entirely known, but it's theorized that potentially because they're more distal, they have shorter routes of collateral flow, so therefore the Tmax delay is just relatively mild compared to a more proximal occlusion. So again, always check the lower thresholds, the mild delays in the 4 to 6 second range on the maps to make sure you're not dealing with one of those occlusions that can be missed if you just look at the summary. So thank you for your attention. I hope you learned something. And again, thanks for joining me on this neuro on-call case set. Have a good one.